Okay. This patient was admitted at our facility, Mloganzila. So me and my colleagues, we attended the patient. He's a 56 years old male who is right-handed, presented with a right-sided weakness for the past 24 hours prior to the admission. Dr. Joseph, you're welcome.
Thank you, Mudhihir. These few weeks, so delighted to have neuro cases because I have interest in that area. And um, in discussing any neuro cases, I talk every time here is that all you need is to put down two things. One is the duration, like temp of the disease, how is it evolving, and then number two is trying to localize the where the lesion is, like to say where the disease is located in the neural circuit, starting from the brain to the muscles. So the purpose of Mudhihir telling us the patient is right-handed or left-handed is that you want to know the dominant hemisphere of the patient, as you know. So most people are right-handed, and so most people have a dominant hemisphere on the left side. And even the left-handed people, 80%, 85% of them still have dominant sphere on the right side. So when we say duration, is that we want to categorize like a disease which occurs abruptly, the different diagnosis will be different from a disease which occurs like progressing chronically. So this patient says right-sided weakness started 24 hours ago, but you have to ask, how is it? Like maybe in the first minute they had upper limb weakness, and then in the 12th hour they had left lower limb weakness. It will be different for someone who had weakness at the moment, like I'm speaking here, and in the next minute, whole of my right, all of my right side is weak. So that we get it from the history. But if we but now put down in that category, we say these neuro diseases which occurs abruptly, like in seconds to minutes. These are usually neurovascular in nature. Think of a stroke. Someone is walking, all of a sudden they can't walk, they have weakness. Also, another thing which occurs abruptly is a seizure. A seizure is something just captures someone suddenly, and then without forgetting is the trauma. So trauma also occurs abruptly, and then you move on from there. You say there are diseases now which occurs in hours to days. Like this can be in that category because 24 hours, maybe it progresses, I said, first hour, second hour, and then 24 hour. In that category, you have infectious processes and immune-mediated diseases of the neural circuit. And now this is not in that category, but you also have subacute diseases and chronic diseases. In that category, you have other diseases like tumors and all sorts of other things. So I think in this case, we would have maybe a hyperacute disease or acute, and we'll be there. Like we'll think infectious processes, immune processes, neurovascular processes, and even a seizure in patient who present with a post-ictal state with a weakness, post-ictal paralysis. Yeah, so that aside, if you think in that, you'll be prepared to encounter problems and solve them in the HPI. So also localization is not hard because a neuro disease should be localized in one of maybe 3 or 4 or 5 places, starting in the brain or the spinal cord or the peripheral neurons or the intermuscular, the neuromuscular junction or the muscles. But you look at the complaint, you realize, can this be maybe a muscle disease? You say less likely. Muscle disease should there is no disease that can affect the muscles of only one side. The same apply to peripheral neurons. The spinal cord is possible when you have a disease on one half of the section of the spinal cord, you can have it. But again, to say in that category, you have to ask the patient if there are signs and symptoms originating from above the neck. That will remove that category. So if it's the neuro, if it's the cord, hemisection of the cord has to be the cervical and no disease above the level of the neck. So you say most likely this is a disease of the left side of the brain, and which can be, as I said, immune-mediated infections or neurovascular. Again, the brain, a lot of things in the brain. You have the hemispheres, you have the brainstem, cerebellum. Where exactly? Most likely, because weakness comes from the motor centers, which are localized, I think, in the precentral gyrus, which is in the frontal lobe. So, having said that, now information which will be coming up, I'll take them and put into different categories of what I was talking about, and it becomes a bit easier. Not to say that neuro is easy, but makes it a bit easier to dissect the case. Thank you, Mudhihir.
Okay. Thank you to Dr. Joseph for that information. It's very, very educative. As Dr. Joseph said, that the aim of saying this patient is right-handed is to know the dominant hemisphere, which will be the left one, in which the language centers are located over there. So this patient was aphasic. So most of the information we like the second person, who was his wife and his daughter. So we can have some deficit of information due to the patient was aphasic. So the last seen norm of this patient was around 2 a.m., which was a day before we saw the patient. He was drunk on that day. He came late at that time, was drunk. So he went direct to his room. And in the morning, around 10 a.m., his son found him conscious, but he was unable to talk. During this day, his wife was not around. His wife was traveled. So in that room, he was just alone. So in the morning, his son, around 10 a.m., he just went there to see if his father was wake up, but he found him conscious, but he was unable to talk. And he was just sit on a couch. He didn't sleep on the bed. So initially, he thought that it's just hangover due to drinking alcohol. So he left just his father there. And in the afternoon, he went again to give him food. But he found his father was on the same position, sitting position, and he tried to wake him up, but he noticed that he was unable to wake up. However, he was conscious. He was looking at him, but he was unable to talk. And he was unable to move his right hand and leg. Therefore, he was not able to talk, to walk, to dress or feed himself. And also the mouth was deviated to the left with drooling of saliva. They tried to feed the patient, but he was unable to swallow. However, he was having choking when fed. At this time, this young son was just alone, so he called his sister, who was at work at that time, and the sister said, wait for me until I come back in the evening. So when he came back around 6 a.m., they were still thinking of hangover of alcohol. So they tried to call one of the nearby doctor. They told him, if you are saying that those symptoms are suggestive of probably of stroke, so rush the patient to the hospital. So it was around 7 a.m. when they take the patient to the hospital. However, during this time, there was no any convulsion reported, no any loss of consciousness or tremors, vomiting, fever, difficulty in breathing, or any external bleeding. On the past medical history, like 5 years ago, this patient was diagnosed with gout. He was having symptoms of joint pains, multiple joint pains. And when he went to the hospital, they told him that you have gout, so you have to stop eating meat. And they gave him medication, which was taking irregularly. When he feels some pain, joint pain, he was taking fluxostat and pain. However, for like 5 years, he was complaining of on and off headache, which was not properly characterized because the patient was not able to talk. However, like 6 months ago, he was also diagnosed with hypertension, and at this time was having a severe headache. He went to the hospital, they checked the blood pressure and was having very high blood pressure, around 200. So he was diagnosed with hypertension and was given antihypertensive, amlodipine and losartan. However, also he was taking irregularly, mainly when he is having headache and something like that. His daughter reported that at home they have a DP machine. So at some point they check him. Most of the time the pressure is very, very high, above 200. Few moments he's having like 170. If he's having like 170, they say, today is somehow good as compared to his normal. So they didn't much bother of the blood pressure because it's always high. So he's just taking the medication irregularly, especially after having some sort of headache. There is no history of having any cardiovascular conditions such as stroke. There was no any trauma reported or using any other medications apart from those which I have mentioned. And this is a former telecommunication engineer. However, he was dismissed due to drinking habits. He's heavily drinking. So currently, before having this condition, he was just doing a part-time jobs. If he get a job somewhere, he's doing it. Yeah. And he divorced to his wife like 4 years ago. He consumes about 18 units of alcohol per week for the past 20 years. And he smoked cigarette about 10 pack years for the past 20 years. However, he stopped like 6 months ago after being diagnosed with hypertension. And in the family, there is no any history of sudden death in the family or having a cardiovascular disease. That is all about the history. Is there anything maybe Dr. Joseph would want to hear?
Thank you very much. This very nicely cracked case, I can say. And yeah, so let me take it from here and before maybe we hear the exam. Okay. So I talked that tempo of the disease, how the disease evolves, very important to localize a disease. Like, oh, sorry, I was muted. Okay.
Okay, we can hear you.
Okay. Yeah, you did hear what I was saying. I was muted.
No, I was hearing you.
Okay. Okay. So yeah, so the patient was seen last normal 2 a.m. and in the morning you find that the patient is unable to speak. It means as I said, now we know the disease, the duration that the disease progressed from normal of the patient to completely abnormal, like in a span of, I think that's 8 hours. So no one knows when it happened. In that category, again, seconds to minutes, maybe second to minutes, maybe patient went to sleep and no one knows, in just slash over time they had this weakness, or maybe the weakness progressed slowly when he was sleeping. So we can say we have two things. We say we have an hyperacute process which occurs second to minutes, or we have something which occurs maybe hours, not days, hours. So we have hyperacute to acute process, and here we can't rule out stroke. Number two, infectious process of the CNS, plus another one can be immune-mediated processes. But what is the one to think of first here? Well, you should think of a stroke before doing anything else, because if patient is within time and you can access the proper management, you can save them, because stroke is a devastating disease afterward. So everything that Mudhihir was saying here still localizes these diseases to the left side of the brain. As you're saying, you told the patient was right-sided, so we say dominant hemisphere should be the left, and the patient is aphasic. Again, right hand and leg inability to move them. We've talked about it. So yes, mouse deviation is very important. So as far as there is also symptoms and signs above the neck, it means it's the brain now. We don't have to think of the cervical spine anymore. So this is the disease of the left hemisphere of the brain, and the differential diagnosis I talked. I would think a stroke before doing anything else, but we say here no conversion, but that's not true if you think of it. Uh, the thing should be no witnessed conversion, but no one knows. Maybe this patient was sleeping, convulsed on the bed, and then what you are seeing now is a post-ictal paralysis, which will go away within hours to some few days. Another thing is the story of headache that started 5 years ago. So this is of particular importance in this patient because, you know, um, when you approach headache, you say headache is either primary or secondary. And secondary headache is the one there is something that is causing headache. Maybe you have a flu, you have a headache, it's secondary headache. You have a malaria, you have headache, that's secondary headache. And then primary headache is these are the one that you all talk about every single day: tension headaches or migraine or trigeminal neuralgic headaches. The category is 5 types of headaches. So 5 years, you say maybe 5 years is too long. Maybe this is primary headache. But remember, before you say something is primary headache, you have to do imaging. But I think we will have more information if we think this has to be a secondary headache. And then if it turns out to be a primary headache, no problem, because primary headache, the management, we can control them. But if it's secondary headache and you assume to be primary, you lose a lot of things. So in a new headache, because now the patient is 56 years old, 5 years ago, patient was 51 years old. In a patient who is above 50 and they have a new headache, you have to think of a giant cell arteritis, GCA. Doesn't matter the characters and whatnot, you have to do the labs later, ESR therapy and see, because around here we don't do the blood vessel biopsy to diagnose this disease. So put that aside, and if that's the case again, and I think of stroke, maybe they're related in some way, we'll see later. Patient having hypertension which is not controlled. So you wonder, is this hypertension not controlled because the patient is doing irregular meds, or even on those days that the patient gets the meds, pressure still uncontrolled? You look at the meds. I think you mentioned losartan, and what other med did you mention? Yeah, amlodipine and losartan. So these are good meds, and what it's just 2 meds. Okay, if I see the patient is not controlled, what I'll do here is I'll add something with hydrochlorothiazide and see if it's also controlled, and if it's not, I consider resistant hypertension and see what's in that category. But what we know now, this patient has risk factors that put the patient at risk of having a cardiovascular and cerebrovascular diseases like stroke, which we are talking about here. And also patient is consuming excessive alcohol plus cigarette smoking. All these puts the patient in risk. So to put simple things simple, not too complicated, to say this is a stroke unless proven otherwise. If we prove otherwise later, now we have to activate other differential diagnosis of what can look like a stroke. So I think we should proceed.
Mudhihir, if you are speaking, you are muted. You can unmute yourself and speak. Hello, Mudhihir.
Yeah, yes. Do you hear me?
Yeah,
Do
yeah.
you hear me?
Yes, yes.
Okay. Okay. On examination, the patient was conscious with a GCS of 15. Other parameters of the general examination were essentially normal. However, the vitals was significant for the blood pressure, which was highly elevated, 210 over 112 millimeters of mercury, with other parameters, including the RBG, was normal. Coming to the nervous system examination, the higher centers was not much assessed due to the physic of the patient, but the most significant one were the cranial nerves, starting with the optic nerve, in which the pupils were equal in size and reactive to light, and we did a fundoscopy, which was significant for the anteriovenous nicking, which was seen, and the cranial nerve number 5 was we found there were reduced sensation on the right side of the face, the other one being just normal. And cranial nerve number 7, the facial nerve, there were symmetrical forehead wrinkling, bilateral, able to close both eyes tightly and symmetrically, in a bit of full smile on right, and he was having flattened light nasolabial fold, droop of the light corner of the mouth, and drooling. Cranial nerve number 9 and 10 was having just dysphagic and was aphasic. While the accessory, he was having reduced right shoulder slug and head was turned mildly weak to left. And the hypoglossal nerve, the tongue was slightly deviated to the right on protrusion with slow lateral tongue movements. On motor examination, was having hypotonia on the right limbs with reduced power of 0, and hyporeflexia with a positive Babinski sign on the right lower limb. Other examination were essentially normal, nothing abnormal which was found. Dr. Joseph, any comment or anything from the examination? However, let's try to be quickly. The time is not our friend.
Yeah, thank you. So, good exam technique, and I think still reinforcing what we was talking about in the history prior. I think I should pick some. So we already say patients are phasic, and you know how is a phasic. One thing to teach here, I see in my junior colleagues and my hospital, is that Mudhihir did a good job saying this patient is aphasic because you can recognize. But you can sit in the morning report and someone is present and say patient was confused, and you start wondering, why should a stroke patient be confused? The confusion is a global thing of the brain. And when you go to the bedside of the patient, you realize they thought it's confusion, but it's not. You know, patient who is phasic, like not mute, but aphasic. Mute is like what you see in psychiatric patient. You ask them and they don't say anything because they don't want to talk, or they select who to talk to. Aphasia is that patient is trying to say something, but they can't. Like, and you look at them, they're disappointed. Like, what's your name? And there's, and then they can even cry that, why can't I talk? I can think, but I can't talk. So yeah, think of the speech centers of the brain on the frontal lobe again, where this pathology is more likely happening. What is shown is a fundoscope AV nicking. I think I can recall it. Is hypertensive changes on the retina when you do the fundoscopy. Still saying this is a chronic hypertensive patient who is not controlled. Motor exam, a lot of findings, which again localize the same thing. Cranial nerves are affected. You wonder, we say cranial nerve localizes the brain to the brainstem. Why are we talking about them here? But the brainstem get those information from the motor cortex, or motor cortex down there to the nucleus of the cranial nerves to the muscles that the cranial nerves affects. And of importance, reinforces that this brain pathology is the cranial nerve number 7 being involved only on the lower side, because cranial nerve number 7, the peripheral cranial nerve number 7, innervate the muscles of facial expression, on the top and on the down one, but the top one gets the dual supply of the two nerves. So even if one part of the brain is affected, it's only the part of the face that gets a single supply, which is the lower side, and the upper one of the hemisphere will be intact and will still control them. Yeah, so if you have a pathology like this, we localize in the brain, this is an upper motor neuron lesion, and in upper motor neuron lesion, you usually say everything is up, but we are told here there is hypolyphlexia, but you say in acute settings, you have hypolyphlexia. Is when you see a stroke patient, for example, admitted in the ward, they have hypolyphlexia. But when you see those patients after a few days or months in the clinic, you realize they have hyperlyphlexia. A positive Babinski still localizes to upper motor neural lesion that we've talked about. So still, Mudhihir, I can say, I can't take my mind away from a stroke. And this patient first needs a CT to rule out if there is hemorrhage.
Mudhihir, when you speak, unmute yourself. I muted you when Joseph was speaking to increase audibility.
Okay, I didn't know if it's mute automatically. Okay, Dr. Joseph, that is the CT.
Yeah, so the CT now shows what we were talking about here. So first of all, to teach everyone here, you do a CT in a patient that you think has a stroke. The thing is to rule out hemorrhage. Why am I saying that? Because stroke is clinical diagnosis. The CT is not to diagnose stroke; it's to rule out hemorrhage, like acute onset of neurodeficit. That's a stroke unless proven otherwise. You do a CT rule out hemorrhage, and as you can see here, you see a hyperdense lesion in the maybe left basal ganglia, and this is a bleed. So I can say, and it's an hypertensive bleed in that area, the region that there is that lesion. And so Mudhihir, I can say so confidently that we are dealing with a hemorrhagic stroke in this patient. Okay.
Yeah, you are correct on the description of the CT. However, the report from the radiology, there were other findings which I didn't get a clear image to put it here, which the patient was also having a focal hypodense on the right thalamus and left aspect of pons, which are in keeping with the chronic lacunar infarcts. And also he was having a deep white matter hypodense bilaterally. What does those information tell us?
Can you repeat the findings?
Okay, the first one which you described, we are very correct, so I have nothing to add to it. Other findings which I was not able to put the image are focal hypodense on the right thalamus and the left aspects of pons, which are in keeping with chronic lacunar infarcts. Together, the patient was having a deep white matter hypodense bilaterally.
Okay. So the first thing is the deep white matter stuff. And we see that a lot in a patient that are above 50. And what you do is that when you see it is that you look at the patient. Do they have risk factors? Like in this patient, to have uncontrolled hypertension, excessive alcohol drinking, cigarette smoking for so many years, you control those risks. But these other lesions that you're saying, hypodense lesion on the you mean on the right
thalamus.
right on the right
Yes.
thalamus, and then another one on the
Left.
on the
Left
left
of pons.
left of pons. Yes. um So you have lesions apart from this bleed that we are seeing. We have lesions elsewhere, and a CT probably is not something that is qualified to characterize everything that we see in this patient.
Yes.
But I can say one might choose to go further and do an MRI, but still, when you see a CT like that, there is a finding that you expected, and it's something else which we are silent. You know, a patient like this maybe might having slow thrombus going, slow thrombus that are going to the brain in different parts, and then what you're seeing today is a culmination of that process. So you don't just end up doing non-contrast CT or MRI in this patient and saying, okay, these were also strokes that were not that maybe were not identified prior because of patient has risk factors. So you have to go back the heart of the patient and try to find out, is this heart also throwing out thrombi everywhere in the brain? So we're talking about finding out the most common process in that category, which is atrial fibrillation. So you do at least an EKG to the patient, or even you can go further and do a 24 hours Holter to see that process. But again, another thing that I didn't talk about here, maybe we say this is the patient who had chronic headaches for 5 years, and then all of a sudden we are seeing now they are bleeding. So another differential diagnosis is that maybe you don't see it here, but maybe the patient had a tumor which is sitting there, and then today is the day that that tumor bled, and maybe you're not seeing the tumor here because the CT when really bring up the MRI, you also see that. So you say stroke, hypertension, but maybe not. I've seen patients with a tumor, they live with the tumor, and all of a sudden they come up with the tumor which is bleeding, and you have a bleeding tumor of the brain. Yeah, Mudhihir, I think you should proceed.
Okay. Let's see the CBC now. Can you comment from the ones which I've highlighted with the red?
Can we have all the labs and then I comment all together?
Oh.
So to save time.
Okay. So this one you have already seen it. Mainly
Yes.
it's yes. Okay. Here the coagulation profile. Seen.
Yep.
Okay. Here the renal function test and the electrolytes. Seen, eh?
Yeah, sure.
Okay. This is the urine analysis. And here the liver function test together with the enzymes. Okay. Comments on the labs before we are going to the other images.
Yeah. So let's see the CBC. Yeah. So as thank you for highlighting, because it becomes easier to talk about it. What we are seeing here is that this HB is above all I've seen, and trust the HB and the hematocrit are all elevated. So we now move from everything we are talking about and start talking about in a patient that with an elevated hemoglobin. So when you see an elevated hemoglobin, you shouldn't rush and say it's a pathology in itself. So it can be a secondary process, or it can be a primary process. If we had everything, if you have everything in this in patient like this, you should send an EPO, erythropoietin, to say if this is secondary or primary. So if EPO is also elevated, okay, you say if EPO is elevated, is the one which is causing elevation there in the hemoglobin hematocrit. This is secondary process, and secondary causes are so many, including dehydration, cigarette smoking, living in high altitude. But again, that shouldn't take you to 19, 18, 19. I don't think so. If EPO is low, it means the hemoglobin is out of control. The RBC is out of control. Like the erythropoietin is down because it's scared of that process, and then they are still going up. And so that becomes a primary process, a primary hyperproliferation of the RBCs. I'm blinding on the name here, the most common differential diagnosis, but it will come for me later. But yeah, so I'm blinding on it. But yeah, yes, thank you, Hassan. Polycythemia. So not polycythemia vera before. Polycythemia is just elevation in the HB hematocrit, but polycythemia vera, which is a clonal proliferation, like it's a cancer of the blood. It's not an easy thing. Another thing is the myeloproliferative disorders, in which polycythemia vera is among those processes, which I'm not seeing them here because some of them will have elevation in platelets or elevation in the white count. We're talking about things like essential thrombocythemia, myelofibrosis, CML, things like that. So if this, I don't know if we'll be able to send EPO, but if you're not, let's assume it's primarily. And if it's primarily, it's interconnected with things in this patient, things like chronically elevated blood pressures, headaches. They're also a part of these things. And another thing you should ask the patient is what happens when you shower with hot water. They say they have sensitivity. Also, polycythemia vera is an hypercoagulable state. You can have thrombosis anywhere. I've seen a patient that I presented to David who had recurrent PE because of that DVT-PE. So another labs, Mudhihir. I think nothing. Yeah. That K, I want the K. The potassium. I see the potassium is elevated. And to be honest, when I see a potassium of 6.5 in a patient like this, I think I would call the lab and say, I don't trust this. What's the cause of hyperkalemia? Like in what you see in the ward, these are patients you see with hyperkalemia, a patient with impaired renal functions, which is not the case as I'm seeing here. The creatinine is on the borderline high, and we expect this in a patient who is having stressful events like this, which is not a problem. But a K of 6.4, patient is just hypertensive, and then normal creatinine, I'll call the lab. So there might be, I'll send another test, maybe there might be a problem with how you draw the blood, put your tourniquet, or the sample stays for long before it's sent for the lab. But it was repeated 3 times, still elevated. The last one is on the upper limit of normal. Can't think of much things about aside from renal dysfunction. Yeah, so I think uric acid, if told that patient is known to have gout, maybe that's not so important. Okay, yeah, so this is a positive urinalysis with some protein and RBCs. A protein +1 in a stool which is not taken the early morning sample of urine you can say is orthostatic proteinuria. But when there is blood and you realize there is nothing traumatizing the patient, you can take positively the +1 protein and say this is significant. And now you think the nephrons shouldn't allow protein to pass. When it allows, you say it is dysfunctional. And if it's protein alone, you say I think glomerulopathy, glomerulonephropathy, yes. And then if there is blood, it's not just it's dysfunctional, but it's inflamed. You have glomerulonephritis. So are we having glomerulonephritis in this patient? Probably yes, because we're also having uncontrolled hypertension, although the age is somewhat not in that category, but you can put that aside and say, is this hypertensive nephropathy, stuff like that. Another, yeah, so what we are seeing here is transaminitis, and the good thing is the AST-ALT ratio of above 2, and the patient who is takes excessive amount of alcohol. I can say this as a alcoholic liver disease, Mudhihir. Easy to explain like that, and maybe not related to what we are seeing here. Next. Yeah, what I'm seeing here, Mudhihir, is the infiltration more on the right lower zone. The right lower zone is the dominant side to be affecting a patient who was aspirates. When a patient who was choking, they were feeding the patient. Or we have to educate the public. You should rush a patient like this to the hospital, not feed them. And even if you see them in when you see a patient with stroke in the hospital, you test swallowing. If they can't swallow this, they choke, you put in GT. Very bad prognosis when they start choking. So I think this aspiration pneumonia / aspiration pneumonitis, which we are seeing in this X-ray. Do you have any other thing, Mudhihir?
Mudhihir, remember to unmute if you are speaking.
Dr. Joseph.
Yes, we should proceed.
Okay, I'm saying that you are afraid of commenting on the heart due to AP view.
Yeah. Oh, good. So it's not that I'm afraid. So the chest X-ray is not an imaging to assess the heart. I think those who told us back then the limitation of these investigations, that they did that, but I can tell you, if you have time, try to take some and measure the 0.5 thing, send those patients to echo, you will see surprising things. So you say, okay, there is cardiomegaly here, but I think if you are in the center with an echo, you shouldn't do that.
Okay. ECG?
Yeah, so usually ECG are scary, but you have to think what you are looking at when you do the EKG. Like in a patient like this who has a stroke like this, and then I have thought about AFib, what I'll be looking at is that maybe I'll say is the AFib here, because if I can strain to find the hypertensive changes, they won't affect change anything. I know the patient is have hypertension, but this patient is different when you give me an ECG patient with a chest pain. And yeah, I know we were told to read the rate rhythm axis and everything, but yeah, let me try to do that here. And I can say this a sinus rhythm, looking at the lead number 2, this sinus rhythm is regular and the rate is somewhat borderline. Yeah, the axis is normal, and okay, non-significant T wave changes. ST, they are normal. I think not so significant findings in the CCG, except for some ST elevation in V2-3, which I think they're suggestive of hypertensive changes and nothing else. Yeah, Mudhihir, we should proceed unless there is something I missed. You're muted.
That is the echo. Any comments? Quick.
Yeah, also seeing is I think the LVH is the hypertensive changes.
Okay. Yeah. Another investigation, you mentioned the serum EPO.
Yeah, so another thing is that if I do serum EPO, it will tell me whether this is whether this is a primary process. Another thing is I'll be that echo is important, that it hasn't said whether the patient has these alcoholic excessive alcohol drinking patients. They are something they are out of maybe healthcare. There is no time maybe to go and just, things happen on their own. Maybe they can have infective endocarditis and you never know. But when you do an echo like that, lowers the probability, although it doesn't rule it out, but we haven't heard whether the patient has a fever or what. So at least I can say the thing I'm seeing on I'm seeing on on that CT, the hypodense lesions, maybe they are not thrombus thrown out by the heart because there is no AFib, maybe there is no effective endocarditis. So what are they? An MRI will be good to say also they are not tumors. And if still we say they are thrombus, we can say they're coming from a hypercoagulable process the patient have. With that HB with hematocrit, I say maybe it's P vera, and so to diagnose P vera, I think you need is it a JAK2 or genetics a test or something like that. Yeah, so I'll do that EPO. If EPO is high, I'll do that JAK2. If before that, I will have done the MRI to say what I'm seeing is there is no tumor in that brain. Back to you.
Okay. Due to time, let me go quickly. We did other investigations. We did the peripheral blood smear. However, it was in keeping of polycythemia and also the infectious or inflammatory process, but not any other significant. Yeah, we also did the serum EPO, as you said. It was found to be in normal range. And also the JAK2, as you mentioned, it was undetected. Any comment, Dr. Joseph?
Okay, so we can reframe the problem and say, if EPO is normal, so it means that was a secondary polycythemia. Maybe because of alcohol dehydration. I mean, cigarette, alcohol, I'm not sure. Cigarette and dehydration. And should we say we are moving too much in this side and we shouldn't be doing this? Yeah, I think everything else can explain this, because hypertension and controlled hemorrhagic stroke, still I'm thinking, what are those regions which are scattered in the brain of this patient? So I can't rule out the possibility of having an MRI to correctly say what are those. Is this the end or?
No, however, we didn't do an MRI due to the patient was somehow severe. So we from this one, we can say somehow the patient is having like the secondary cause of polycythemia. So we did an abdominal ultrasound. The aim of doing the abdominal ultrasound was to rule out if the patient is having the splenomegaly, because in most cases of the patient with polycythemia vera, they tend to have splenomegaly. So that is the end of the investigation. So what do you think now will be the diagnosis of this patient?
Okay. So let's go back to the baseline, and maybe start from there. So this is the patient with a stroke. So when you have a patient with a stroke, the next step is to find what's the cause. And the cause of strokes sit in three places. They can sit in the heart, they can sit in the brain. They can sit in the vessels of the brain and the vessels leading to the brain. And also they can sit in the blood itself. So in the heart, I think we've done a good job, although you need some other thing like a 24 hours Holter. We didn't see anything like that. And then vessels, we're not seeing anything suggesting that this patient has a vasculitic process that can lead to a stroke, because there was nothing, and then all of a sudden it's a stroke, except for the headache, but no other symptoms. And then blood itself, maybe hypercoagulable state. Now, which one? It's so hard to say if there is an hypercoagulable state, which one, because for me, this shouldn't be P vera with the normal APO, with the normal APO, with the normal erythropoietin. That's secondary. You move from there. P vera is the primary process that causes that thing. Other hypercoagulable state, you think should you proceed and find them out in this patient? I think not, because you have hypertension uncontrolled. So which if stays there for long can cause the blood vessels of the brain, for example, to form plaques and maybe dysfunctional blood vessels that can rupture or clog to cause a stroke. So I can say this is just a stroke, and maybe we shouldn't be doing that unless if this patient was given enough antihypertensive and no response, or with that, even that hypertension of 200, you can still say, what if that's a secondary hypertension? That's a different problem, which will help us in controlling the hypertension of this patient. And in finding out the causes of secondary hypertension, now these are things, others, like most of them hormonal, like things like hyperthyroidism, hyperandrogenal, aldosteronism, Cushing, and all sort of things, and structural causes as you're doing the renal ultrasound and there is nothing. So if I was seeing this patient, Mudhihir, I wouldn't do much. I would say it's just a stroke. Patient has uncontrolled hypertension. Let's control the hypertension, give patient statins, manage the current stroke, prevent another stroke, unless maybe I'm missing something because of time and you have to teach me maybe if there is something.
Okay, I see a comment from Hassan Che, if I'm not mistaken. He's telling that smoking is a risk factor of polycythemia, which is quite correctly. And also having the negative of JAK2, it doesn't rule out the PV, because JAK2 is almost present in almost 95% of cases, but however, there is that 5% which we have to do other investigation, which we were unable to do all of them. But it's been said so, we are still entertaining the diagnosis of the polycythemia. However, we didn't conclude if it was really secondary because the JAK2 doesn't rule out the primal, which is presenting with the stroke, which was acute left basoganglia hemorrhagic stroke with mild MACE effects. But also having the polycythemia, it's also the risk factor of having the uncontrolled hypertension. That's why even the patient was kept in antihypertensive, the pressure was uncontrolled. And also the hyperuricemia, which was there for almost 5 years, it is also being due to the polycythemia after the breakdown of the RBCs. They tend to have this hyperuricemia. So I have some few teaching points. I will rush quickly, then Dr. Joseph will come to have a reflection. So as been said, polycythemia or erythrocytosis is the blood disorder characterized by elevated hemoglobin and hematocrit. It increases the thrombotic risk through the hyperviscosity, platelet dysfunction, and impaired microcirculatory flow. Can be caused due to primal or the secondary, and we have a number of causes in the primary and also the secondary. But the most one which we are highly thinking due to this patient is smoking. Is the patient is a chronic smoker for almost 20 years now. He was smoking heavily. So how does the smoking lead to polycythemia? As we know, when someone smokes, release carbon monoxide, which tend to bind to hemoglobin, and carbon monoxide is high affinity to hemoglobin. It's said to be about 200 to 250 times as compared to the oxygen. So when the carbon monoxide binds to hemoglobin and forming the carboxyhemoglobin tends to shift, there will be a left shift of the curve, and they tend to bind tightly to the hemoglobin, and they also call the oxygen, the little oxygen, which bind also to the hemoglobin to tightly bind and not released in the tissue. So the patient will have tissue hypoxia, and then the renal will respond to release erythropoietin, and which will go to the bone marrow and tend to release a lot of RBCs, and the patient will have the erythrocytosis. And most of the patients are symptomatic, most of them. However, the patients, when came to the hospital, most of them, they will have secondary hypertension, seen in 40 to 75% of the patients. Some will have hyperviscosity, seen in 30 to 60%. Thrombotic events are seen in 20 to 40%. However, the thrombotic event, the splenomegaly is seen 30 to 75%. However, the splenomegaly is mostly seen in people with polycythemia vera, which is a primary cause, and not seen in secondary causes. Also, the hyperuricemia is seen in 15 to 30%, and 5 to 10% they tend to have bleeding, and some of them, they will be forming a leukemic transformation, 2 to 10%. So if you found a patient with elevated HB and hematocrit, what you have to do, you have to order serum EPO peripheral, and also ordering the JAK2. If JAK2 comes, if the EPO is low and JAK2 is positive, that is PV. Maybe you will need a biopsy to confirm it, but it's, there is a high chance of having a PV. And if the JAK2 is positive and the erythropoietin is normal, here they say you have to repeat both probable PV, so both tests should be repeated, and bone marrow examination should be done. But if you have a negative JAK2 and erythropoietin is still low, PV is still possible, consider JAK2 exon 12 mutation analysis and bone marrow examination. And if you have a negative JAK2 and a normal or high, PV is unlikely, and you have to consider the secondary causes of the polycythemia. So there are diagnostic challenges, as we were unable to measure the relative clones and the rare exons mutations, which were not tested. And also, we were unable to confirm if the patient was having a sleep apnea, which is very common, leading to hypoxia driving and leading to erythrocytosis. But as the patient was having smoking, we entertained this one to being the most probable cause of having the polycythemia. We have these novel diagnostic modalities which could be done. However, at our facilities, they are not there, so it's hard to do them. The first one is this one is called the next generation sequencing, which involves the myeloid panel, which detects the core mutation that supports possibility of other clone marrow mutations such as TEC2 and the others. Also, we can do ultra-sensitive assay, help in differentiating the secondary and the primary polycythemia. On the management part now, as Dr. Joseph, you said, it was very challenging to control the pressure of these patients. Initially, we started with the labetalol, but still the pressure were still high, above 200. We add with hydralazine, fedipine, telmisartan, still the pressure were very, very high. On the third day, we consulted hematologists. They came and see the patient, and they did a venesection. From there, we started to see the improvement of blood pressure coming down from the fifth day. And they did like 5 sessions, and later on the pressure came down about 160s, 150s. But initially, antihypertensive was very, very difficult. So for the patient who is presenting with hemorrhagic stroke, we have to control pressure. We have to do venesection so as the pressure to come down. And when the patient is stable, we have to reassess the hemorrhage, HD and hematocrit, and if there is any ongoing risk of thrombosis. If these ones they are controlled, we can initiate aspirin to the patient and cytoreduction, whereby we give hydroxyurea, which will tend to inhibit the bone marrow to release a lot of RBCs. And on my right side here, this is the approach on management of patients with polycythemia vera, who is not having hemorrhagic, maybe stroke. We can move on with these steps as have been shown here. Reflection, Dr. Joseph?
Okay, everyone, I think I need like 2 minutes. And Mudhihir, thank you very much for presenting the case. And at the end, there is things that I think should be taken in another context, because it seems the patient is, you can say, responding. It's so normal around here. Patient with hemorrhagic stroke, you give them antihypertensive, they don't respond. And I tell you the reason. If I ask you what dose of Rabeta you gave, I believe, because this is cash and you have to give a drip, which we don't do. And then another thing is these patients have a lot of things. ICP going up, they have a headache. So hard to like correct their pressure. But I have my notes here of polycythemia, and I think what we can do, like to learn more from your case, is to repeat this lab from another to repeat this test from another lab, because can you see my slide here, right? Okay. So what we shouldn't be mixing is that polycythemia is just a word. Polycythemia vera, this is a disease, and trust me, it's a cancer. And polycythemia is just a word. It means elevated HB. And when you have it, like what I'm showing here, now this all is a journey trying to find out what is it. So let's say you've done your EPO as in your case, and EPO was I think in your case the
EPO was normal, 13.
Yes, EPO was normal, like down here. So polycythemia vera doesn't exist in the differential diagnosis, except when it's positive, is where you come here and you are among your DDX will be polycythemia vera. So the best thing, if patient responded to venesection, and I'll talk to hematology, what if we repeat these tests? Labs, we see clinically Labs are there to help us. Yeah, so I think this should be taken as a context. And these are there. If you take someone from coming from maybe Kilimanjaro, they might have a bit elevated HB, or someone who's smoking like this patient, but they won't. It doesn't put that patient in any risk. But if you call it polycythemia vera, it's a distinct diagnosis of its own, very bad, can cause very bad things. And for me, I would think in this case is that this patient is uncontrolled hypertension, as many other patients who present with hemorrhagic stroke. They had distracted vessels over time, which on that day that they came in, ruptured and bled. Period. And then polycythemia is the thing you are seeing from the other side, because even polycythemia, if it causes anything, it will cause it's an hypercoagulable state. We expect it to cause ischemic stroke, maybe, if that's the case.
Yes.
But thank you. That's what we are here for, to learn. And for example, maybe I'll have to sit down and see if I'm missing anything from my side. But thank you very much, Dr. I think we are out of time. A lot of comments in the chat. I didn't have time to look at them, but thank you, everyone. Do we have a minute, maybe, David?
Yeah, I think the chat was very active today. So can we just start with there was a number of people here. Hassan was very active. So Hassan, if you have anything to share, and then anyone else with anything, you can just raise up your hand. Maybe we can use a minute or two each before we close the session. Anyone who has anything. Yes, Rajabu, please welcome.
Okay, thank you. So, Dr. Mudhihir, thank you very much for a nice presentation and a very interesting case. Also, Dr. Joseph. So, my issue, as Dr. Joseph said, that so if you see the imaging, the CT scan, the area of bleeding is more suggestive of hypertension. Yeah, I concur with the Dr. Mudhihir. Probably, most of the time, probably this hypertension of this patient, it might occur because of polycythemia, because polycythemia has the potential of resulting into hypertension, which is secondary hypertension. And then that can explain, that's why even during management of giving an antihypertensive, that's why it was very difficult to control. So for me, I don't know, but in the diagnosis, the first culprit for me, it could have been hypertension. Yeah, you can say that a patient had polycythemia. If I'm not mistaken, you said like almost for 2 years, the patient was complaining of headache, recurrent headache. Probably since then he had this presentation. So probably another explanation is probably he had the ischemic stroke, which transformed into what? Into hemorrhagic stroke. So those are the two explanations. If we can have, by that's when we can say that probably this stroke occurred because of polycythemia. But for me, the first culprit, I could have considered hypertension. Then that hypertension is secondary to what? To polycythemia in with respect to this case.
Okay, thank you, Dr. Rajab.
Thank you, Rajabu. Anyone else? I see you had some comments there. And Hassan, if you are still in the chat, you can please unmute and share something. Anyone who has anything, you can just unmute or raise up your hand. And Sizo, please welcome.
Yeah, thank you so much, Dr. David and Dr. Mudhihir. Yeah, this is one of very interesting case. I don't have anything to take on a diagnostic part, because for me, from the beginning of the presentation, I thought it was stroke. It was cardiovascular accident with initial vitals 220s, past medical history of hypertension. And I feel myself this HB was an incidental finding. At the age of 56, having polycythemia without any prior event about mid-age, it's unlikely. But my take was on the way of diagnostic. Currently, they are saying, actually on the way of examination, currently they're trying to say that whenever we are seeing patient with low level of consciousness. They discourage, especially medical patients with low level of consciousness. They are currently discouraging using GCS because it's biasing to patients with medical illness. Assume this patient is having stroke, coming to you, you're using GCS already basic. So they're trying to advise using other types of score, which is called a 4 score. I know most of you have heard of it. So in the word calendar, whenever you're trying to present a patient with stroke, try to avoid GCS because typically it was assigned for patient with a head trauma, head injury. That was number one. Number two, as a comment, is from the approach before the diagnostic part. There's this very important scale used for assessment on the level of weakness is called NHSS score. I see most of colleagues around, whenever trying to present a patient with weakness, they want to know by the time you're seeing a patient, what will the NHSS score? Because at some point in time, it will change the management. So I argue upon the presenter next time, maybe because you had a diagnosis, but for us, when we are listening to you, it is important for us to take us from stroke to polycythemia and see the link in between by showing those differences. And this is also a very interesting case. I concur with all doctors around. We should go and read to see if this is actually polycythemia or otherwise it was an incidental finding. Thank you.
Okay.
Thank you.
Thank you.
Kisoka, I see your hand is up. Please welcome.
Thank you very much, Dr. Devi and colleagues Mudhihir and Joseph for a very well discussion. So mine is still, I'm still in the diagnostic part as far as we do not know whether it was a primary polycythemia or a secondary polycythemia or otherwise. But to Mudhihir, because I trust that they have the patient, I will put my coin. Still, we have to search for the cause until proven otherwise, as far as we are internists. So an ultrasound was done, and the reason for Mudhihir was to check for splenomegaly. But to me, the ultrasound, the reasons will be a bit different, is to check for renal masses. Though they just wrote no renal masses detected, but I will proceed further because there's a pattern that I've seen, and I have a confession on this. There's a patient who was also a medical personnel, worked in the psychiatric unit, who had a renal cell carcinoma, and stayed with that carcinoma, imagine, at Muhimbili for years. And then this was detected later on, then the disease was advanced. So we have only one limitation with an ultrasound in terms of detection of renal cell carcinoma, which can give you the pattern that we have seen, the pattern of hematuria, the polycythemia that we have seen, hypertension. In this patient, initially, they might have a normal renal workup, and everything comes back normal. So with that experience, to me, I prefer going for an abdominal CT, and I will be a bit biased on this. I would prefer to go for an abdominal CT to be certain, because we have a limitation on our ultrasound. So the lesions, the muscles that are less than I think it's 1 to 2, if I'm not mistaken, millimeters won't be picked up easily on an ultrasound. This is how we missed that particular patient, and actually came to be diagnosed last year when I was in my 3rd year. Then we came across this patient, and this patient had a renal cell carcinoma. So I'm not sure, but please, if it's doable, this will be my comment to the patient and to the colleagues either. Thank you very much.
Thank you, Dr. Kisoka.
Thank you, Michael. I was seeing some comments from, I'm not sure if he's still around, but then we also have Ihewa. Do you have anything, Ihewa Gaula? If you have anything, please welcome.
I think we should close.
Yeah. So I see her and Hassan are not around. Yeah, I also have some things. Hassan, please welcome. I think we can have a minute.
Thank you, Dr. Joseph, for the nice elaborations. I would like to comment sometimes for the case of the primary vela, when you do full by picture, we find there is elevated white blood cell as well as elevated platelets. Sometimes you may find patient have thrombocytosis on full by picture for the case of the primary vera. But someone was asking about how does polycythemia cause hypertension. It's all about the hyperviscosity of the blood that can lead to hypertension. Thank you.
Thank you very much. This is Mudhihir. Thank you very much for bringing the case. You can see the sort of discussion that we've been having. It's been a busy chat, many thoughts. I think there is still some debate on the issue of polycythemia. I would and the cause of the bleeding. So there are two facts here. This patient has hypertension, a very high blood pressure, and I also think that polycythemia in this patient is not false polycythemia. It's true polycythemia, because we, at least clinically, although Mudhir did not talk very much about on whether this patient had any reason to suspect volume loss, but we did not see that. The uric acid was probably one of the things that are explaining increased red cell turnover. And another thing, Joseph, the hyperkalemia with the renal function test that we saw, the hyperkalemia also could be because of hemolysis. So we are not sure for how long the sample was staying, before it was tested. But then I know it can go both ways, especially with polycythemia. Sometimes there can be false hypokalemia, that is, the RBCs, it's like the RBCs are taking up the potassium. But also when massive hemolysis is happening, you can have hyperkalemia. And therefore, two facts here: the patient has hypertension, has polycythemia. Now, whether the bleed was because of hypertension, very probable. But the hypodense lesions that were reported, it's probable that also the patient was having some ischemic changes, probably due to the thrombotic risk that comes with polycythemia. So, very interesting case. I think we've not come to conclusions, but Mudhihir, you've done a very good job. See what you've done today. You've brought a case, and it has sparked a lot of discussion and activity. So thank you very much.
Okay, thank you too.
I think, David, still there is one thing you're confusing me. The hyperviscosity comes with polycythemia vera, not any polycythemia. So yes, patient has polycythemia, we all agree. But to call it polycythemia vera, you need those, that what the picture says. You need to have a low EPO, you need to have a positive JAK2, or a low EPO with a negative JAK2. There is still things there. But yes, polycythemia, but it's not vera.
Yeah. This is not polycythemia vera, or at least we have not come to a conclusion of polycythemia vera. A number of things are missing to say that. The JAK2 mutation, the normal levels of EPO, and of course, because these are associated with myeloproliferative disorders, as Mudhihir said, we would expect a splenomegaly at least. So not polycythemia vera, but then it's very likely that when you talk of any polycythemia, really can come with a hyperviscosity, not just vera, because you have increased. So it's the polycythemia itself, because you have an increased red cell mass, that comes with hyperviscosity, not just vera, I believe. So yeah, a number of things here which spark a lot of discussion, and I believe maybe we can continue. We'll upload this video on YouTube, and so people can share their comments, and maybe we'll come back to another clinic or no next week, and I think a number of people will have reflections, and we can spare some time for people who have gone and done some reading to enlighten us more. And I think we can come back to this case and discuss further. But I believe, Mudhihir, you've taken some comments, and you will go and work on them in order to make sure we reach closure for this patient and help the patient.
Okay.
Yeah.
Thank you.
Otherwise, thank you very much, everyone. It's been a wonderful day. I think we've not seen an attendance like this one. So towards the end, we have more than 50 people. But today, I was monitoring the numbers. We went up to 90 something, maybe 94, 95. So for those who are joining for the first time, we meet here every Sunday, and just disturb those people who share the link with you to also share with you a link to a WhatsApp group where we share the links every time, and the links to the video, so you can you can stay in touch and have the links every single day and make sure to attend. Otherwise, many minutes past the hour, because I think the discussion was very interesting. So have a good night, everyone, and see you next Sunday.
Good night.
Okay, good night.